Well, we really want to thank the Tennessee Medical Association for inviting us to speak on this really important topic. And we're calling it Patients at Risk, the Importance of Physician-Led Care. I'm Rebekah Bernard. I'm joined by my co-author, Niran Al-Agba. And tonight what we hope to do is give you some really good background on the issues that we have, and then like kind of an elevator pitch as far as what you can do to make sure that you spread the message to your colleagues, to patients, and to legislators. We are members of a group called Physicians for Patient Protection. Our mission is to ensure physician-led care for all patients and to advocate for truth and transparency regarding healthcare practitioners. And we encourage everyone listening to join us in that mission. And we also want to encourage everyone listening, if you're not already a member of the Tennessee Medical Association, we highly recommend that you do that because we really have power when we work together.
So we wanted to leave you with kind of two main objectives tonight and to understand how to talk about this subject. It's so important, but it's very controversial, as I'm sure you all know. In a nutshell, there are 5 decades of research that back the fact that nurse practitioners and physician assistants provide top quality care when supervised by physicians. That has been a well-studied topic. However, there are absolutely no randomized controlled trials that have evaluated the care provided by unsupervised physician assistants or nurse practitioners. And that's a really important point that gets missed a lot of the time. We simply don't know if it's safe. The AANP is famous for saying that more than 50 years of research has consistently demonstrated the excellent outcomes and high quality care provided by nurse practitioners. And again, our answer to that is not that nurse practitioners are not capable and they're not great colleagues and they don't provide high quality care. In fact, they do. But that 5 decades of research is really consistent that every randomized controlled trial was supervised 100% by physicians. So we did want to talk about a couple of studies. We won't bore you with research all night, but Cochrane's database, which I'm sure you're all familiar with, has collected 18 studies that they feel meet criteria to evaluate this question of nurses being substituted for physician care. And what's interesting is only 3 of those studies were done in the United States. And so I thought we'd kick off with that, as well as throwing in 2 from Canada. The first was done many years ago, actually more than 50 years ago, by Lewis. It's one of the United States studies, and it occurred at the University of Kansas Medical Center. 66 patients divided into 2 groups. So 33 were nurse patients and 33 were physician cared for by physicians. And they were mostly women over 50 of lower socioeconomic status. And they had to have one of 5 chronic conditions. Those were hypertension, arteriosclerosis, obesity, arthritis, or a musculoskeletal problem. And those 5 conditions had written protocols that they then had the nurse practitioners provide care for. It was a 100% supervised study. And again, as you know, when research is designed, it asks a question. So this study was designed to ask only one question: would patients accept nurse practitioners instead of physicians for their care? And that was a resounding yes. The issue was, to be honest, the 33 cared for by nurses needed to attend 350 visits, and the 33 patients cared for by physicians had their care parameters met in 153 visits. So there was an early sign that it would take twice the resources to provide equal care. Before I go on to the next 2 US studies, I want to talk about my favorite study, which is the Burlington Trial. It was done in Canada, and it was done by Sackett and Spitzer, who were 2 very well-known sort of evidence-based care gurus. Ian Hay and Pat Sweeney were 2 overwhelmed physicians in the province of Ontario, and they postulated, could our really experienced nurses that we've worked with, George Lefroy and Isabel Vandervlist, could they be trained, have a little bit of extra training to do chronic kind of patients or follow-up care of really simple conditions and allow us to expand our practice? They were full at the time. So actually this study, the Burlington Trial, was the 4th randomized controlled trial done in history. And in a nutshell, it essentially, the question was, could the capacity to deliver primary care be increased by having advanced nurses work in collaboration with their physicians. And in fact, they could. It was a resounding success. And these two family docs could expand their patient capacity by 22%. So they could continue to take new families. And actually their care became kind of legendary because these four really provided top quality care. However, there are a couple of caveats. When they are supervised, they can provide care as good as physicians about 55 to 67% of the time. So these chronic follow-up, what we would call simple care patients, still required intervention by a physician at least a third to 45% of the time. And the Chambers study was done very similarly. It sort of backed up the Burlington trial, 100% supervised. There were no different in patient outcomes, again, when supervised. So the best US study was done more than 20 years ago, according to the Cochrane database. And this was involving the Veterans Administration Medical Center in Baltimore, Maryland, 450 patients. It was 100% supervised. And essentially the conclusion was very simple. In a primary care setting, nurse practitioners may utilize more healthcare resources than physicians. That was the only statistically significant conclusion they could draw. And just to give you the comparison groups, 9 nurse practitioners with 18 years of experience and education, 35 residents with 10 years of experience and education. And then the 10 attendings they chose were relatively new attendings versus more experienced nurse practitioners, so that the total years of experience and education were similar to be 18 years. So most of those attendings had only been in practice 7 years. Those were the comparisons. They looked at kind of what they ordered and things along those lines. The NPs ordered more lab tests, they ordered more imaging studies, and that was statistically significant. They utilized more healthcare resources than the residents and the attendings. And here's what's shocking, actually, and it wasn't statistically significant, but it's certainly interesting that while the patients of the attending physicians have higher more acute conditions and they were more sick overall, the nurse practitioner patients had a 41% higher hospitalization rate, translating to about 13 more hospitalizations per year out of 100 patients. And they had less sick patients. And while that wasn't statistically significant, it may be clinically significant. So let's talk about my other favorite study to talk about, which is Mary Mundinger's study that was published in JAMA in the year 2000. This is kind of what I would say the battle cry of nurse practitioners fighting for independence. And what's interesting is it compared 17 physicians and 7 nurse practitioners in a community outpatient primary care clinic. 1,300 patients, predominantly low-income, transient Hispanic women who would go back and forth between New York and then Dominican Republic. It looked at health status, which is a kind of subjective condition in low-risk patients over a 6-month time period. Now, here's what's interesting. They talk about it being an independent study. When you delve into the true details, number one, New York State required collaborative practice during this time, and every nurse practitioner was allowed to choose a physician mentor. It's really important, you know, these 7 nurse practitioners were doctorally trained. They all had doctorates of either nursing practice. They also were their department heads. So the head of geriatrics, the head of family nurse practitioner, and the head of pediatrics was included in this study. These 7 nurse practitioners spent 6 additional months learning what a differential diagnosis was, learning how to interpret lab and imaging studies. And then they shadowed physicians, particularly focusing on emergency care, cardiology, orthopedics, and radiology. And so they were sort of provided these mini residency programs before they started this study. So in summary, despite all that resource utilization and the, trying to find the ideal 7 nurse practitioners to put against these physicians, the summary was no differences in health status or health service utilization. The nurses still tend to order more laboratory tests such as UAs or hemoglobin A1Cs. They more often measured the height. They had no difference in their referral patterns. But again, I want to be clear, they chose physician mentors, and they absolutely had to have a physician sign on if they were going to admit anyone to the hospital. And the patient satisfaction was a little bit higher from physician-led care. So to kind of summarize the Mundinger study in a nutshell, the critique that Cochrane really hammers on is that this one study has the highest bias of all 18 studies. Essentially, Mundinger had a vested interest in how this study turned out. And there's a longer convoluted thing about her working for United Healthcare and that becoming a big supporter of nurse practitioners much later. So a lot of people had a vested interest in this, and there was a lot of money that was involved. And so subjects were not randomized. Neither patients nor personnel were blinded to the intervention. Outcome assessments were not blinded. And the study authors actually only chose to report favorable data. For example, they threw out the pediatric data. And I thought that was a really interesting aspect of the study.
So what you're hearing about are studies in which the nurse practitioners are the creme de la creme. They are experienced, they are doctoral level in many cases, but what's really happening on a day-to-day basis? Well, I'd like to give you a case example. This is Antoinette Thompson. She's a family nurse practitioner. She had worked as a firefighter, paramedic, and an emergency room nurse, and then she decided to become a nurse practitioner. She went to an online nurse practitioner school at the University of South Alabama, and she was required to complete 500 clinical hours as part of her training, and she received those hours providing prenatal care to low-risk women at a county health department. She took her examination and she was certified as a family nurse practitioner. And just after she was certified, she applied for a job working in the emergency department at Mercy El Reno Hospital in Oklahoma. And she was hired as a family nurse practitioner to work in an emergency room. And this was considering that Mercy Health Systems is a multi-billion-dollar organization with hospitals across Oklahoma and other parts of the Southeast. And they advertised that they provided physician-led care. In fact, on their website, they said, our emergency room is, quote, staffed round the clock with a team of highly trained emergency physicians. However, this was not the case. In fact, Mercy Hospital Systems had a habit of hiring nurse practitioners to work independently, even though Oklahoma is not an independent practice state, both in the emergency room and as hospitalists. And the day that Alexis Ochoa was brought into the Mercy El Reno Hospital, she was greeted by only a family nurse practitioner and not an emergency physician. Alexis was 19 years old. She was a college athlete and an honor student. She was perfectly healthy until one day she suddenly developed chest pain, shortness of breath, and she fainted. Her boyfriend called 911 and an ambulance brought her directly to Mercy El Reno. That's where she met Antoinette Thompson, who found out that she had no medical history. She took birth control pills and ascertained that she was not stable. Her blood pressure was low, heart rate was rapid, and her oxygen levels were dropping. So based on the information she had, she began a workup. And as part of that workup, she ordered a drug test. That drug test came back with a presumptive positive for methamphetamine, which unfortunately would turn out later to have been a lab error. The patient's history was not consistent with methamphetamine, but the nurse practitioner got focused on that and totally neglected to continue on with a differential diagnosis. And despite that, she treated Alexis for over 11 hours. She never once contacted her supervising physician. In fact, in court records, it was determined that she didn't even know who that person was. After 11 hours of just repeated attempts at just not effective treatments and the wrong treatments, she finally transferred Alexis to a tertiary center where she was correctly diagnosed with a pulmonary embolus, but unfortunately she died. Later on, the family of Alexis Ochoa sued Mercy Health Systems, and they did win a $6.2 million verdict against them. And that's how we know an awful lot about the details of this case. What happened to Antoinette Thompson? Well, she quietly moved away from Oklahoma and she took up residence in Iowa. And as of just recently, when we checked the website, she's still listed as an emergency room provider there at Veterans Memorial Hospital. And Iowa is an independent practice state. And also the Veterans Administration is independent practice for nurse practitioners. So one can assume that she may be continuing to work there and without physician supervision. As far as whether or not she was sanctioned, of course, we know the hospital paid a large settlement for the malpractice claim, but Antoinette continued to practice, and it was only a year after the lawsuit and many years after this happened that she finally was sanctioned by the Board of Nursing, and she received a 1-year suspension, a $1,000 fine, and some remediation of work that she had to do, some coursework, and that was the extent of her sanctioning. So how did we get to this point? I think it's really important just to take a quick review of the history of nurse practitioners, because what you heard from Niran when she talked about some of the early studies was really how nurse practitioners were intended to be. The whole idea of nurse practitioners came about in 1965 when Henry Silver, a pediatrician, founded the first program with Loretta Ford, a nurse instructor. And the idea was to create extended nurses that could go out into the community, especially in rural areas, specifically to provide well child care, immunizations, and education. But within about 5 to 10 years, the number of programs rapidly grew. There were then 60 programs in just 5 years. And the government got interested in it. There was supposed to be a physician shortage that was coming, and they liked the idea of having nurses act as physician extenders. And so the government invested money in research. And in 1977, they actually mandated that rural health centers must hire a certain proportion of nurse practitioners and physician assistants to incentivize them to be hired. So with that increase in funding from the government, increase in training, nurse practitioners grew in strength and power, and they began to request that they should be paid directly rather than through affiliation with a doctor. And they began to seek what they call full practice authority, beginning in rural states, making the argument that these were underserved areas and that they would be able to fill the gap. 2010 was a really important year for nurse practitioners. The Institute of Medicine published the famous Future of Nursing report. And it's interesting because it's called the Institute of Medicine, but there aren't that many doctors on the boards there. In fact, the board that created the Future of Medicine report only had 3 out of the 18 members were physicians. And those physicians were actually heads of insurance companies and invested in pharmaceuticals. Now, the Institute of Medicine Future of Nursing report called for a massive increase in the number of doctorally trained nurses, and it called for equity between nurse practitioners and physicians. That same year, the Affordable Care Act actually massively increased funding for nurse practitioner training, and it created a new designation of nurse-led clinics.
So here we are today with a map that has obviously the green states are the full practice states. Those with yellow are reduced practice, and then the red states, like Tennessee, have a restricted practice where you have oversight by physicians. And what's interesting is obviously California has passed now a transition to independent practice after a certain amount of hours. And Florida did the same. It's 3,000 hours of supervised practice, and then you may practice autonomously. In the VA, that number's after 5 years. Looking at a graph, I think the next slide has the number, there we go, of nurse practitioners. And what I think is probably the most important fact on this slide is you really see an uptick after 2010. So that's the funding that the ACA really kind of pushed forward. And you see they sort of cross the 10,000 mark and go exponentially grow between 2000 and 2014, almost by about 6,000 to 8,000. So diploma mills are really important to understand. There's more than 400 nurse practitioner training programs in the United States compared to 179 medical schools. No medical schools do their curriculum online. Of the 400, about half of those programs are 100% online. These programs mean they really, the students go maybe at the beginning for an orientation and then at the end to show their final project, but everything else is completely done online. And so in addition, you can see there's this, sorry about my phone in the background, there's this additional 100% acceptance rate at a lot of these schools. And here's just some examples of different states like Clemson and Regis, they're 100% online. And then there's this second problem. Well, there's other problems, but these programs are becoming shorter and shorter. There's this direct entry nursing program, there's accelerated NP programs, and then there's 100% online programs. And the difference with direct entry is essentially that you don't need to have bedside nursing experience at all. In fact, you don't need a nursing degree at all. You could have a psychology degree, a degree in engineering, any sort of bachelor's degree. No bedside nursing experience. You can apply, get your master's in nursing, become a nurse practitioner, and depending on the state you're in, you could work independently. And these different programs you see on here are about 16 months to 3 years in the time for an education. So within a few years, you can be practicing on patients.
Yeah, and sometimes we show people this and they say, this can't be true. We don't believe this. How in the world is somebody going to become a nurse practitioner without ever having worked as a nurse? In fact, the reason why nurse practitioners don't need to go to school as long as doctors is because they've worked as a nurse and they have a wealth of clinical experience to draw from. But that's not true anymore. And here's an example. This is Christopher. He is a nurse practitioner and he posted on social media to share his experience. And it says here, first day of work as an NP, orientation training for the next 2 weeks, and then I'm all on my own in my primary clinic. And he's working at a Minute Clinic, which hires mostly nurse practitioners. And you can see over here on the right, he shares that he has had no RN experience, but it did not hinder him whatsoever. And he did his bachelor's degree in psychology. He did an accelerated bachelor's degree in nursing and then transitioned right into his master's program and graduated within about another year. And he also gained a psychiatric nurse practitioner certification. So you see that this is real, this is happening more and more, and programs are jumping up all over the place. And I have to tell you that a lot of nurses don't like it. In fact, nurse practitioners that trained at brick and mortar institutions, they're deeply concerned about it, and many have complained, but they're being told by their organizations not to speak out. In fact, this is a slide from the closing ceremony of the American Association of Nurse Practitioners 2019 conference. Margaret Fitzgerald, who is a nurse educator, she presented the topic and she shared with nurse practitioners that if you have concerns about education or full practice authority, you need to stay quiet and not express that. So let's talk about how we've gotten to this point, because it's really quite amazing to see in the last 50 years the growth and the changes that have occurred. And the way they did it was through cooperation, political advocacy and funding, and rebranding. Now, we can learn a lot from nurse practitioners because, as doctors, it's awfully hard to get us to agree on anything. But this proves that if you all work together for one common goal, wow, you can really make an impact. And that's what they did. In 1993, nurse practitioner leaders came together for a summit. 125 different leaders from all different associations and parts of nursing. And they formed a coalition that later became a lobbying organization. And their goal was just one, and that was to make direct reimbursement to themselves rather than going through a physician a top legislative priority. And this is a screenshot, and I'm sorry it's a little fuzzy. This was originally behind a paywall. It was originally open and now it's behind a paywall on the AANP's website. And this is basically what their strategic plan is. And I think it's really helpful to see what their goals are. Goal A is that patients will have full and direct access to and will choose nurse practitioners as their healthcare provider. B is that they'll be leaders in healthcare and they'll be placed in high-level positions in business and government. And C, that they'll be known for their authority, leadership, and expertise. And I think goal D is really one of the most interesting, which is that they want to have, and they make their agenda, full pay parity, to be paid the same as physicians. And so the way they've done that is through political activism. And what they did was they worked very hard to engage their members. They provided lectures and plans for calls to action. They taught their members how to communicate with legislators, how to tell stories, and really how to get the word out. They gave recognitions and special thank yous to leaders. They also engaged their students. And I spoke to a doctor who was previously a nurse practitioner, and she told me that they would often, if there was a big legislative day, they would cancel class at nurse practitioner school and they would take a bus, all of the students, up to the Capitol. Everybody would get off the bus and they would go there to have a presence. And she said that was not an uncommon phenomenon. In 1996, they hired a full-time lobbying firm, and that was a really strategic decision because that was the year that the Balanced Budget Act was signed by President Clinton, and that did give them provider status. They also did something really interesting, which was to make a strategic plan to move nurses into political positions. Just a few examples. In 1989, a nurse, Carol Ann Lockhart, was named to the Physician Payment Review Commission. She was one of 13 members, and she was a nurse. In 1993, Mary Mundinger, who you've already heard about, was appointed to Hillary Clinton's healthcare task force. In 97, Shirley Chatter, she was a nurse and the commissioner of the Social Security Administration under Clinton, and she was tapped to create a nurse health policy fellowship program that would take nurses and put them in positions where they could work side by side with legislators and lobbyists and learn how to be able to influence healthcare policy. In the year 2000, Sheila Burke became the chief of staff for Bob Dole, and she was a nurse and later was appointed to the Medicare Payment Advisory Committee that would later recommend direct payment to nurse practitioners. So this was a really strategic decision. And a lot of this came from direction of the Robert Wood Johnson Foundation. Now, the Robert Wood Johnson Foundation is the philanthropic arm of Johnson & Johnson, which is the world's largest producer of household products. And their philanthropy donates lots of money to many organizations, but they have a special heart for nurses, and they've contributed $674 million since their inception to promote the work of nurses, and in particular, this Executive Nurse Health Fellowship Program. They also were the ones that actually came up with the whole Future of Nursing report. They planned it, they subsidized it, and then they later donated money to the AARP to implement the recommendations from the report. They also gave millions of dollars to different media organizations like NPR, specifically to strengthen media reporting on nursing. And none of this is a secret. This is all available on their website. So the question is, why is the Robert Wood Johnson Foundation so invested in advancing care provided by nurses? And, we don't really know exactly why, but we do see some links that, may be contributing factors. Of course, as I mentioned, Robert Wood Johnson is the philanthropic arm of Johnson & Johnson, the world's largest manufacturer of healthcare products in the world. And they also have many subsidiaries that make drugs. For example, Janssen Pharmaceuticals is a major manufacturer of opioids. And actually, they were recently sanctioned because they were trying to talk to prescribing physicians and nurse practitioners and encourage them to prescribe their opioids. And then, of course, Robert Wood Johnson works closely or has a relationship with CVS, which owns Minute clinics that employ nurse practitioners, and those are right in the pharmacy. And they also are linked with the AARP, which makes profits selling insurance plans to Medicare patients, including United Healthcare. So you can just imagine that a patient goes in to a CVS Minute clinic, they see a nurse practitioner, they pay with their insurance card from United Healthcare, and they get prescribed maybe a drug produced by Janssen Pharmaceuticals, and maybe they pick up some Johnson & Johnson products on their way out the door. So we don't know, of course, the definite links, but we do begin to see a lot of financial potential incentives for why you would want to have more nurse practitioners prescribing products.
So the third arm of their actions were to rebrand, and they've rebranded multiple different times, but these are two of our favorite advertisements. The We Choose NPs advertisement was sort of this idea that you can choose to have someone besides a physician take care of you. And when you choose that, then patients win. And of course, get your PA's opinion. And notice in the ad, which is interesting or crazy to me, it's a doctor, looks like a doctor with a white coat and the stethoscope. And so essentially saying, if you get your PA's opinion, or just say PA instead of physician assistant. And so the PAs especially have worked to drop the assistant word. I believe it's Duke that's just transferred over to calling them physician associates. And so there's this element of rebranding and marketing that's going on, and it's effective. So the history of physician assistants will kind of look a little bit like that of nurse practitioners. Around the same time that Henry Silver was starting out in University of Colorado, Eugene Steed at Duke was trying to figure out what military medics coming back from Vietnam should be could do as a career, and thought it would be great, since they'd had all this trauma experience, to be able to sort of transition into helping physicians take care of patients. And as we march through, Henry Silver's back, and he figures out calling them child care associates would make sense. And federal funding occurs in the 70s. This idea of optimal team practice, just say PA, occurred in 2019, and then physician assistants won independent practice in North Dakota. And of course, during COVID, there has been a big push for expansion of the scope of practice for physician's assistants. And the same kind of pipeline growth you saw for nurse practitioners has also gone on. I don't know that it's quite the same rise after 2010. It's just been a steady growth. But again, the government didn't necessarily invest in physician assistants the way it did with nurse practitioners. So what's interesting is the length of education. I mean, most of you that, all of you that are physicians will know this, that the time in training that's required is very different. So physicians have a minimum of 11 years of training, obviously 4 years for undergrad, 4 med school, and then 3 or more of residency. Nurse practitioners do sometimes an undergraduate degree in nursing, sometimes not. And then they have a 1 to 4 year master's or doctorate program. There's no residency required, 5 to 8 years. And physician assistants have an undergraduate degree, a 2 to 2.5 year program, no residency. So their time is about 6 to 6.5 years. And the hours required, obviously, physicians, 15 to 16,000, and then essentially in med school, 6,000, in residency, 9 to 10,000. Those of us who trained like Dr. Bernard and I before the residency hours were instituted were more along the lines of 20,000 hours of experience. And nurse practitioners are looking more at about 500 to 1,500 hours of experience. And that is not necessarily has oversight or is standardized. Could be 500 hours with pregnant women at a healthcare facility, could be 500 hours somewhere else that they found their own preceptor. And then physician assistants, usually 2,000 hours.
And, we talk about those 500 hours, and it really depends on what the nurse practitioner's scope of practice as far as what those hours are going to be in. Now, there have become so many different routes that nurse practitioners could take that in 2008, nursing leaders came together and they created a consensus model to try to put a little bit of standardization as to what kind of training should parlay into what type of career path. And they decided that they should break it into a population focus. And so you have family nurse practitioners, which is actually the most common type of nurse practitioner, adult geriatric, neonatal, pediatric, women's health, and psychiatric mental health. So for each of these, whatever you choose, you would need to do 500 hours in that area. And I'll just point out that for the psychiatric mental health, the 500 hours that you are now certified to take care of mentally ill people, 100 hours are required to practice on children with mental health problems. And then you are certified to take care of mentally ill people, quote, across the lifespan. So 100 hours for children. Now, there is supposed to be a difference between acute and primary care. If you are a family nurse practitioner, you are certified to train in primary care, which is supposed to be stable patients. You should not be working in an acute care setting like a hospital or an emergency room. There are different tracks for certification in acute care, and nurses are supposed to know what scope they're supposed to work in. If they're a family nurse practitioner, they're not supposed to work in acute care. But as you've seen, there's often a lot of confusion about that, and sometimes employers don't know, the practitioners themselves don't know, and then that becomes a problem. And then we'll just point out that specialty care does not exist in the consensus model because there really is no standardization. There's no residency program. There's no special standardized track in any specialty. Basically, you would just shadow somebody or work with someone in a specialty, and then you call yourself a specialist. And I think it's really interesting to look at hours that are required in other professions. So we said 500 hours minimum to be a nurse practitioner. If you want to be a barber, you need to have 1,800 hours practicing cutting hair. If you want to put makeup on people, you have to do it for at least 600 hours. So it's really interesting that to take care of a human life, you would only need 500 hours. In fact, even PetSmart's dogs groomers boast that their dog stylists get at least 800 hours of training before they are permitted to independently to cut dogs' hair. So what is the difference then when it comes to the certifications and the training and tests and things like that? There really is no parallel between nurse practitioners and physicians. So a few years ago, the nurse practitioner advocates decided to try to see if they could demonstrate equivalence between nurse practitioners and physicians, especially for nurse practitioners with a doctorate degree. And Mary Mundinger was one of the people that was really interested in doing this. She felt that nurse practitioners needed a doctorate degree so that they could get on par with physicians. So they created a great experiment in which they had nurse practitioner doctoral candidates take the USMLE Step 3, which is the test that we physicians take before we're licensed to practice medicine in our intern year. Now, this wasn't the exact same USMLE as we take. The National Board of Examiners did publish a white paper where they clarified that this exam was not including the same in-depth assessments of fundamental science, clinical diagnosis, and clinical skills that the physician USMLE offered, but it was sort of a watered down version. The first year they offered that was in 2008, and 45 candidates took the exam. The pass rate was 49%. They continued along the years, and then in the year 2013, when 18 people took it, only 33% passed, and that was the end of that experiment. They discontinued it. They said for limited utilization, but really the experiment had failed, and these doctoral degree nurse practitioners could not pass the same exam that physicians pass at very high rates, about 97% pass rate for the USMLE Step 3.
So while we were researching for this book, we sort of came up with why we think there's this significant difference. And there's something called the Dunning-Kruger Effect. Essentially, two psychologists, David Dunning and Justin Kruger from Cornell University, postulated that people with less experience overall tend to overestimate their abilities. And without an adequate knowledge base, it's really hard to recognize your limitations. And if you think about it, expertise is attained essentially with 10,000 hours of experience. That's why this hour discussion matters. Across many disciplines, chess and tennis and radiology, it's been studied that someone needs at least 10,000 hours to be able to understand their limitations properly and then to continue to learn and expand. So there's this illusion of superiority, and that's essentially how we explain those with the least knowledge who insist that they don't need help and they know what they're doing right. And unfortunately, when you're working on human beings, mistakes can cost people their lives. So the issues that the AANP will kind of put forth, they want full practice authority in all states. And, many of the legislators obviously are working on these sorts of bills throughout those states that still have restricted practice. And the reasons that they will use to push this forward is essentially that it will improve access to rural areas for patients. So nurse practitioners will be trained, they'll go into these rural areas and they'll improve access for patients.
We're going to show you that that's not really true. But before we do, I think it's really important to address the access issue, because this is what we hear all the time. Well, is access really such a good thing? And the answer is no. A study was performed in 2018, and it showed that more patients die worldwide due to poor quality healthcare than die due to lack of access of healthcare. And that's because when patients get the wrong diagnosis, a delay in treatment because it's the wrong diagnosis, they get the wrong medications, then they are more likely to be harmed than if someone just left them alone. So the answer to access is it only is valid if access is to high quality care with trained professionals. And as far as will nurse practitioners even go into these areas, it's not turning out to be the case. Here is a map, and the AMA has these maps for every state, and it shows the overlap between nurse practitioners and physicians. And you can see there's a blue dot, there's actually a blue triangle for nurse practitioners, a purple dot for primary care physicians, and a significant overlap. We know that only 23% of nurse practitioners even work in rural areas to begin with, and we know that still the most likely clinician to work in a rural area is a family physician. And the states that have enacted independent practice have not seen the promised increase of nurse practitioners into these areas. In fact, a 2012 pilot project gave $179 million to try to incentivize nurse practitioners to work in underserved areas. But after 5 years, only 9% of the graduates went into these areas. 25% worked in underserved, and just 12% elected to work in primary care. And the whole primary care issue is really important because the nurse practitioner organizations say that they are a very high provider of primary care, that 78% of nurse practitioners practice primary care. And they're probably getting that number from the fact that most of their graduates are family nurse practitioners. But the government actually says that only 48% of nurse practitioners practice primary care. So they may be a family nurse practitioner, but they're not necessarily practicing in primary care. They may have started working in a subspecialty setting. They may be opening a day spa or offering Botox or things like that. And we've seen a 40% decline in nurse practitioners choosing primary care since 2004.
So the second myth is that having nurse practitioners have full practice authority and be able to make diagnosis independently and prescribe medications is that it streamlines care and makes care delivery more efficient. And what's interesting is that's completely not even close to the truth. Essentially, in almost every study back to 1974, they utilize more resources. And so they order more laboratory tests, and in some studies, as many as 440% more imaging tests. They perform more unnecessary skin biopsies in dermatology practices. They prescribe more medications, including unnecessary antibiotics, psychotropic medications, and opioids. And one of the most important studies that looked at this was this comparison of the quality of patient referrals between physicians and nurse practitioners and physician assistants. And the quality was not only higher from physicians than it was for nurse practitioners and PAs, but in particular, it was the clarity of the referral question. I'm sure those of you that are specialists understand how frustrating it can be when you don't even get the question the patient's just sent. So again, the referral question, the understanding of the pathophysiology of the condition to begin with, therefore knowing how to refer and where to send the patient, and then the adequate pre-referral evaluation and documentation was better from physicians than it was for physician assistants. So here we are back to Cochrane's database, and I won't bore you too much except to say those 18 studies had 100% physician supervision, physician-created protocols. The high-risk or complex patients and almost all the pediatric patients were excluded. The studies utilized small sample sizes. The average length of follow-up was short, about 14 months. There was really no study that looked at undifferentiated conditions presenting, sort of from like an emergency care or urgent care standpoint. And their conclusions were that in general, for ongoing urgent physical complaints and chronic conditions, trained nurses, such as nurse practitioners and registered nurses, probably provide equal or possibly better quality of care compared to primary care physicians, and probably achieve equal or better outcomes for patients. They probably achieve higher levels of patient satisfaction. And however, consultation length is probably longer and the frequency of return visits was higher. And this is, remember, with physician supervision. So that's the most important kind of detail that gets missed. One of the last studies that they did in 2014, again, was at the VA before they initially sort of said, now everybody can have free practice authority. And essentially there were no differences that were found, but the strength of the evidence was insufficient. It was low to medium. It was never really adequate to make decisions about mortality, quality of life, health status, or hospitalization rates. So again, we still stand by the fact that we have no randomized controlled trials of independent practice that have been evaluated or have even proven it's a safe practice.
And, without that information, patients really need to know. They need to have truth and transparency. There are 183 different nursing certifications. So you'll see a string of letters after someone's name, and it's really hard to make out what that even means. There are doctorate degrees in which patients don't know if they're seeing a doctor because there's a doctor of nurse degree. And by the way, 85% of all doctoral level programs for nurse practitioners are non-clinical. In other words, they're learning about informatics or leadership and not clinical expertise. There's also a doctor of physician assistant studies or doctor of PA, so patients don't always know. And then there's also an appropriation of terminology that's typically used by physicians, like board certified, residency or fellowship, and ologist, like nurse anesthesiologist, and they don't mean the same things. We know what a physician residency means, but a nurse practitioner residency could be a year of 40 hours a week, or it could be a weekend, and there's really no standardization. There's also an issue with NPs and PAs calling themselves specialists. Here's a nurse practitioner who calls herself a rheumatologist because she took a certain number of courses with the American College of Rheumatology. I, as a family physician, could not take any number of courses and then call myself a rheumatologist. That would not be okay, but yet that's okay for nurse practitioners. Psychiatric nurse practitioners is a really big thing lately. That's just blowing up. And a lot of times patients think that they're being seen by a psychiatrist, but it's a nurse practitioner.
And we would be remiss not to mention the fact that NPs are not held to the same legal standard of care in malpractice cases that physicians are held to. And there's three kind of big decisions, and I will leave this to our legal colleagues who are on the call, but Fine versus the Kaiser Permanente group. Actually, Fine was a lawyer who was injured, had a missed heart attack. And essentially, the judge initially instructed the jury that the standard of care would be the same, or the expectations would be the same between the nurse practitioner who missed his heart attack and the physician. But ultimately, a higher court ruled that he had given the jury the wrong instructions, that it was wrong because the standard for nurses is not the same as physicians, and the physician should always be held to a higher standard. Therefore, it was a man in this case, a male physician, his conduct was worse. A second major decision was Simonson versus Kepperd, 2007. And it was a situation where there was a nurse practitioner missed a cerebral hemorrhage. And what they ended up determining was the case was dismissed against Nurse Lehman because the expert that was used was a physician, and they were not qualified to, quote, opine on conduct of a nurse practitioner. And therefore, because that was their only sort of witness, the NP standard of care had not been established. So therefore, the case was dropped, and the patient who lost their life, it didn't matter. The family was not successful in their lawsuit. And finally, Lattimore versus Dickey really nailed, like the last nail in the coffin. A nurse's conduct must not be measured by the standard of care of a physician or surgeon, but by that of other nurses in the same or similar locality and under similar circumstances. So if you cannot get someone to testify to the nurse standard of care, then essentially medical malpractice is much harder to show. And finally, we have this kind of myth / manipulation where, the total number of medical school graduates has kind of remained the same. And there's this debate all the time about a physician shortage. Yet, as you can see over here, we have this crossover between the residency positions available and the total applicants for residency positions. And so the reason I call it kind of a myth is, yes, we really don't have enough physicians out in rural areas. I am one of those, so I know that all too well. But we have 10,000 graduates of medical schools who have been unable to match in their residency programs. And we are now seeing their loans being forgiven because they're essentially, courts are saying there's no hope. They will never become practicing physicians because they can't get into residency programs after 10 years or 7 years. And this is a big problem because these individuals have so much more training than the nurse practitioners that have 500 hours and are just going out to work on patients.
Yeah, I found it particularly poignant this year with the match when I saw that 2,000 graduates from MD and DO programs that were graduating seniors did not match. And that's because there were more medical students graduating than slots. And then another 4,000 internationally trained medical graduates. So this is a really big problem because these, like Niran said, they have plenty of experience and much more than 500 hours, and yet they have no chance of continuing on to be licensed as a physician. I think California is a good case example. They passed independent practice this year with a certain number of hours of collaboration first, but then the same for nurse practitioners. And at the same time, they increased physicians to have to, instead of just 1 year of residency, they must complete 3 years before they can practice. So it's really hypocritical and interesting, and but that's the reality that we're in right now. So of course, we would encourage you to learn more about this topic. You can join our organization. Of course, we encourage you to join the TMA, and we would love for you to check out our book. And we also have a podcast and a YouTube channel with the same name, Patients at Risk. Thanks so much for your attention, and we'd love to discuss this more and take any questions.
Thank you both so much for joining with us, and really all our thanks for taking the time to write this book. I mean, I think this summarizes and goes into great detail a lot of what we all sort of know and we all sort of think, but we just haven't had a resource to lay it all out for us like you guys have done. And I just think it is a very important effort that y'all put forth, and we certainly appreciate it. We've got a few questions, and so we'll in the chat there's some comments too. So I'll try to shoulder a few. I'll try to go through a few of these. Dr. Reddy asked about the physicians shouldering a portion of the responsibility for supervision and how many have abdicated this role and sort of created this sense of independent practice. You guys, are there any, I mean, that's a problem, and I think we all need to recognize that people aren't doing what they need to be doing with supervision. How do you address that?
Well, I think there's a couple of different issues. There's this captain of the ship doctrine, and I know there is your lawyer is on here, so he can probably take this a little bit better. And each state will be variable. But what's interesting is the concept is really fluid. So this idea that there's a supervising physician, and this happened in the Alexis Ochoa case. You know, the supervising physician almost got off kind of easy. It was the physician that she called for advice twice that evening that was a completely unrelated cardiologist at a completely separate hospital and really had no contract in any way or relationship with her, that they tried to have shoulder the responsibility for this death. And we're seeing that right now, even in Minnesota. Those of you who have followed the I think it's the Dittmer case, and where a physician who has no relationship with the nurse practitioner, that she called him from a clinic, did not provide the proper information. He did not admit the patient died. And now the Supreme Court actually has, I think it's Warren versus Dittmer, but the Supreme Court has returned the case to the lower court, saying the doctor cannot be absolved of responsibility because he had a higher burden. Therefore, he is more liable for this decision. And the problem is he didn't even get the information. And I actually know that case a little bit better, but the vital signs weren't provided. The lab studies weren't provided. And I think we just need to protect ourselves as much as possible and essentially, I hate to say this, but essentially treat someone who's not a physician as if we were working with a med student or a resident or even like someone who's shadowing us, because we have to check ourselves. And if we don't, that places us with increased liability.
No doubt. And you know, and that's a whole nother issue about losing that collaboration that even the nurse practitioners aren't really thinking about yet, that the liability will come their way, even though they won't be held to the same standard. So Dr. Butler mentioned that if he remembered correctly, there are over 40 nurse practitioner schools in Tennessee, but only about 5 or 6 with physical buildings. So very consistent. A lot of these are the online services. And then Dr. Leonard mentioned that there's this constant talk about a doctor shortage. He's out in rural East Tennessee in primary care, and he says there are all of these billboards that say new patients welcome. And so Julie Griffin mentioned that there are a lot of doctors in Tennessee still taking patients, but some of them aren't taking TennCare and Medicare because of the payment issues. And I think that brings up another point here, is that this is a health disparities risk in many respects. That I wonder how obviously this is being set up to be a cheaper form of healthcare, a cheaper form of training. Have y'all considered that as far as how do we make this equitable for people who don't have insurance or who don't have access to doctors?
Yeah, I mean, we are definitely seeing a move towards a two-tier system in which those who either have maybe not necessarily the money, but just the knowledge and the acumen to ask for a physician are maybe more likely to get them than somebody who doesn't have that knowledge or doesn't have insurance or is on Medicaid. And we know with an increasing corporatization of healthcare that corporations love to hire non-physician practitioners. They cost less a little bit in salary, although that could change with this pay parity move, but also they order more tests and more ancillary services. So that increases the bottom line of these companies. There's really only incentives for them to hire them versus physicians. So if you go to a corporate center, and unfortunately a lot of our academic centers are turning to this, and it's been pointed out to me that a lot of this growth occurred after the residency hour restrictions occurred and residents weren't allowed to work those kind of hours. And so they began to bring in more non-physician practitioners to fill that gap. And academic centers seem to really enjoy it, and they are really propagating this. In fact, there's a Cedars-Sinai blog where they say, can I see a nurse practitioner instead of a physician? And it says, yes, we really encourage that. They're just as good. And this is, a teaching center. And we see this in academic centers all over the place. And it's really discouraging.
Yeah, no doubt about that. There was a question about the laws preventing bait and switch, truth in advertising, that sort of thing. Yarnell Beatty, our legal person, just says there really are no laws to prevent, consumer protection in this regard. And so I guess we're down to just hoping that people post their qualifications appropriately and represent themselves appropriately. I think like you had mentioned, very much confusion about what a doctor is and what a doctor isn't. And I think the cases in your book really brought that out a great deal, especially with the families and how they thought that they were seeing doctors.
Yeah, absolutely.
That sort of thing.
And I think we could look towards New Jersey because, sorry, Niran, New Jersey, was that the one you were going to talk about?
Well, no, go ahead. I had something different. You go and then I'll go.
New Jersey passed a truth and transparency in healthcare law. And there's been one that's been in committee and then tabled for a long time in the US Congress that I think that all states may want to look at, even especially if we continue to lose the battle. All right, well, if you're going to be independent, you need to have a prominent sign. You need to have the same malpractice. Patients need to know. And so New Jersey does have legislation that's quite good. And actually, even California's legislation is pretty good for what they do require of the practitioners that are independent. So I think there are some things we can do to mandate that there be more transparency.
And I think the other part of this is getting the message out to the public. If any of you have seen the News Nation broadcast piece, the two families, Jeremy Wattenbarger and Amy Ochoa, who lost their children, neither of them knew they were not seeing physicians. And so there was this acceptance or this trust. And I think the most important thing is to be willing to discuss with the public that non-physicians can call themselves doctor. They do call themselves doctor, and that the degree of MD and DO are really what you should be looking for. And I did want to read an old excerpt from Mary Mundinger's book, because I think it's really important that you understand that this was a very well laid plan from the beginning. And what she wrote about how they got Columbia to sign on to have nurse practitioners have kind of parity with them was the nurses were specifically selected after being given hours of careful, nuanced training in choosing the right uninflamed words to respond to the media. Nurses were told to say they were practicing new and well-accepted skills, not medical care. We learned to give the message we wanted to give, which might or might not be an answer to the question we were asked. No one practices independently because patients need care from other professionals. And it was this very deliberate approach to sell the public and to sell corporations and to sell hospitals on this idea that we're not independent. We're just providing nursing care in our standard. And I think physicians, part of this evening, I hope you take away that physicians really need to learn to speak on this subject in a way that is uninflamed, as Mary Mundinger herself said. And that part is not necessarily that any person who provides healthcare is bad or good. Rather, we have absolutely no data showing that nurse practitioners and PAs working alone is safe. And I think that is so, so important. And when you talk to patients about that, they get it. And they really tend to prefer physicians because they know we have the training.
In any other situation, we would have a gold standard that you'd have to measure against. And then you would be either non-inferior or equal to that gold standard. And obviously, the gold standard test has not been done measuring against an actual physician versus a nurse practitioner in a double-blinded trial. They're never going to do that.
Well, they tried to do that with the DNP exam, the USMLE3. They were trying really hard to show equivalence. And as you saw, that was a failure. Someone asked what happened to the 2012 data. And, a lot of what we got on that were screenshots because all that stuff has been removed. They don't want that out there. So probably we couldn't find the 2012. I mean, we were relying on screenshots that other people had gotten and saved before it was taken down. This is not something that they really want to advertise because it didn't make them look very good.
And, the News Nation piece, their nurse practitioner president, she really pivoted on this question that they're not practicing medicine or there's a new definition of medicine. We're practicing nursing.
She said we're practicing healthcare
all the time. We're practicing healthcare. That's right. And we hear this from our nursing colleagues who are pushing for this all the time, that they're not practicing medicine, that they're practicing nursing. And it really, people don't really understand what the difference between the professions are, and it's a very big problem. Dr. Johnson mentions that, the local doctors are getting worn out cleaning up the messes left over from the nurse practitioners who are in either mass or sloppy practice. and we don't have an ability or organization to report them, and how can we fix this? A similar question came from Dr. Hamre that said, where would you put nurse practitioners as far as licensing goes? The nursing boards really are not, tasked with, supervising the practice of medicine, which by all definitions, this is what they are doing. Any thoughts as far as regulatory standards and how we might approach it that way?
Right now, we mostly have the boards of nursing. I mean, that's the oversight board that is in charge of keeping track of anyone who has a nursing license. And I think what each of you can do that would be effective is every single state has a kind of nurse practice act or a scope of nursing. And what they got Antoinette Thompson on, the person who was involved with actually killed Alexis Ochoa, is the fact that it was a very clear designation what nursing was versus what medicine was, and what they were allowed to do and how they were allowed to practice. And she broke those rules very clearly. Admittedly, so did the hospital, but I think that's the only way. And then I think the second way is to talk to the public. Again, I really I've said this many times in many podcasts, I've given up on politicians. I've given up on so many of our oversight and regulatory bodies like various medical organizations, not the Texas Medical Association, of course, but nevertheless, I think it's really important the public understands what's going on and can learn to discern for themselves. And then finally, I think the media can be helpful. And that's what's so important. They did all this media training for the nurses back in the mid-90s. They're still saying we practice healthcare, we don't practice medicine. And I think we need to be more savvy about talking with the media and sharing these stories, because the more the media knows and the more the public knows, the more that we can do to help patients. No doubt.
I will mention that the Coalition for Collaborative Care, which is an organization of all the leaders of the specialty organizations in Tennessee, the physician assistants have created their own separate board, and we've been pushing the nurses to try to get their regulatory domain out of the Board of Nursing into some other vehicle for this very reason. So there's that. And there was a question about graduate physicians, and we had a graduate physician bill. I know they've had one in Missouri. It just seems like it's hard to convince people, even doctors, that this is a reasonable path for someone who didn't match in a residency program. But certainly that would help. At least their medical training wouldn't be wasted, if they're not able to practice. I guess they could go back to nursing school and get a PA degree or an NP degree and do it that way.
Actually, there is a program like that. There's a track where they go to NP. They go right through, go back and become an NP. And that's probably what I would, if someone came to me for counseling and I didn't think there was any way they're going to get a residency, that might make sense. As crazy as it sounds.
There's a mention about we have to still sign a lot of the orders for the NPs that they can't sign themselves. And that's certainly true. I spend quite a bit of my time as a primary care doctor doing that. And one question that I had, one other comment was from Dr. Greenfield, that this is really affecting the nursing shortage, because all the nurses get out and then they want to go become NPs so that they can make more money. I think we saw that during the pandemic, right? We had a real tough time getting adequate nurses in different places. One question I was going to ask, have you heard from, or is there any way or any studies that you've seen with honest polling of regular nurse practitioners to see if, the rank and file, to see if they would, to see how they feel about this, because we really see this being pushed by their academic leaders and a few vocal nurse practitioners. Is there any study or any evidence that we've had more of a non-biased poll or something like that?
I'm sure that would be squashed immediately. They don't want that information out. We hear from nurse practitioners all the time. I get tons of emails. We've had a few that have come on our podcast and been open about it, but most of them say, oh no, I'd be run out on a rail if I shared my true feelings. So I think it would be, I would love to see a study like that. I think it would be very eye-opening and enlightening, but there is nothing that I have seen. And further, I'll say there is no data on any of these independent practice states that have come out that have been done since they went independent. It's eerily silent. They talk about this 5 years of research and they're still talking about stuff from 1966. And the most recent thing, 2000 and what was the Mundinger? 2000. So that's 20 plus years. And there's nothing really coming out that shows any real data right now.
And one comment from Christina Nelson, what is TMA doing as far as truth in advertising? I think we continue to have resolutions that we consider, and it's really tough though, because you really have free markets and free trade and that sort of thing that sort of works against that. But then she mentions that her mother's a member of the board of nursing and their entire meetings are consumed with diversion hearings. That's another reason why perhaps the board of nursing is not the place for a regulation of the practice of medicine. And we saw this in Tennessee. We had a nurse practitioner. He called himself Rock Doc, and he was basically involved with a lot of opiates, as well as some other less savory activities for the opiates. This is what gives all of us as practitioners a bad name, but certainly brings up the point that we need better regulation of these folks. So anyway.
Can I just quickly answer? I see something in the Q&A that is, I think, a really interesting question from Dr. Kripalani. I think it says many NP students seek out clinical hour requirements with physicians to gain experience for their degree. Should physicians be saying no? And that is such an interesting question because I've precepted many NP students before my eyes were opened and PA students. And I have to say my new thing is that if you want to be a nurse practitioner, you should be trained by another nurse practitioner. I only train medical students and residents and other physicians. That's my stance. And I think we need to take care of our own, and I would encourage all of us, if you're not already precepting or mentoring a medical student or a resident, please take the time to do that and tell the nurse practitioners that you can find a senior nurse practitioner to work with. That's my opinion.
And I would piggyback on Rebekah's comment. I almost jumped in earlier to say the same, that these physicians that aren't matching, it really helps them even to spend time in different clinics and for us to write letters of recommendation. And the thing is, this profession is something, I'm a third generation physician. My grandfather was primary care. My father was primary care. And the thing is, there was a time in history where we gave physicians like a hand up. We worked together, we helped each other. And I think that we really need to concentrate on our own. And I too, I do not precept nurse practitioners. I agree 100% with what Rebekah said. And I have the same policy, though I am about to take on someone who didn't match to do a month of pediatrics in between. I have a lot of residents I train. So this year will be the first year I'm trying to help a physician who did not match in residency to now get a match the following year.
I'm actually doing that too. I have somebody, his school's going to let him extend his year, and he's going to come, he's applied for psychiatry and he couldn't match. And I said, hey dude, guess what? Family medicine is pretty much all psychiatry. So how about coming and switching over? So he's going to do that. And is it okay, Dr. Smith, if I also answer this other question from Dr. Kirkland?
Go ahead.
It says, do you have a cadre of NPs and PAs who went back to med school to become MDs and DOs? The answer is we sure do. In fact, Kristen Giordano and McAuliffe, I have to shout out to her because she's one of the person that set this up. She was a PA and she wrote about her experience for an article for Kevin MD, which was really powerful, just talking about that she didn't know what she didn't know. And we hear this all the time from our friends who were NPs and PAs, and they're very powerful. Many of them are willing to speak out, but I will tell you that like many physicians, many are a little afraid to speak out, because if you are owned by a corporation or an organization and you say something they don't like, you will be fired or you will be sanctioned. One of the reasons Niran and I can speak out is because we own ourselves and we can really be fired. So it's great. And it's another reason I say be autonomous if you can, because then you can speak out. But yes, the answer is, and if any of you listening are, we would love to speak with you and have you tell your story.
I'll wrap up with a question from Dr. Hunter Butler, who's one of our CCC, or Collaborative Care Coalition members. He said, "Will y'all move to Tennessee for our legislative session in 2022 to help us work with the legislature?" You know, Tennessee is a fine state. If y'all be most welcome. Maybe we can at least get you as expert witnesses when this comes up. So
we'd be delighted to come to Tennessee. It's a beautiful state, and we love all our friends out there.
We do, but you know, I hope tonight you guys have like the talk points and the things that I think you can really do good work in the legislature, and we'd be happy to be experts.
I think we are certainly much more informed than we were before, and we thank you both, and you know, just keep up the great work. And you know, I can't emphasize enough how important this book has been for those that have read it. It really opened your eyes. And for those of you who haven't, I would encourage you to go to the TMA website and get the discount and buy the book. It's a great read, and you'll just. I mean, I had my video off because you didn't want to. I didn't want to distract y'all shaking my head and just going that over and over again while y'all were talking. So, thank you both so much.
It's our pleasure. And I would say, even if you want to donate copies to your local libraries as well, we've started doing that, a lot of us. So I'm throwing that idea out there that patients are requesting the book and it's not available at a lot of public libraries. So what a great way to get the word out. And
that is a great idea, no doubt. Well, I think we've been well informed, and thank you both so much. Take care. If there's anything we can do in Tennessee or in the future for you guys, just let us know. Okay.
Thanks for having us. You're very kind.
Yes. You're very well. Thank you so much. Take care.
Bye-bye.
Bye.
With that, we'll wrap it up. And like I said, hopefully some of you will get a chance to watch our House of Delegates. We'll be talking about policy and that sort of thing. And then remember the importance of being part of organized medicine, to consider joining the TMA, use our discounted dues for first year members as a way to get involved and at least see what we do and what our legislative team does to try to protect our profession and help us take care of our patients in Tennessee. And with that, Russ, do you have any comment?
Thank everyone for their attendance this evening, and have a good night.
Take care, everybody. See you soon.